for the nutrition tips, actually balance your plate. Sometimes patient dia nak ambil carb saja, tak nak makan ikan, tak nak makan ayam, nak ambil plant-based diet. So you need to educate patient regarding the importance of this balanced diet, high calorie and high protein diet. And then smaller meals, makan sikit-sikit actually is easier to manage with patient with loss of appetite. And you consider the patient preference, regarding the presentation or the preparation of meal. So protein penting for immune function, for energy, and of course to prevent muscle and weight loss during treatment. Kena inform. Kadang-kadang patient tak tahu, okay? And then this rainbow diet just untuk nak bagi cantik, bagi nampak colourful, actually to promote good overall health for patient. And stay hydrated is very very important. Boleh letak dalam air, nak letak macam lemon, lime, tapi jangan pula dia kata letak lemon, lime ini boleh hapuskan sel kanser. No, actually we want to ensure that patient receive adequate fluid intake. So you can, you give the feeding plan to patient, minta dia monitor. Empowerment for patient is very very important. Kadang-kadang diorang comply dekat ward, but when they discharge home, tak buat. Okay, so you need to also counseling patient to boost up the calorie, the protein intake, to fortify the intake. Modified consistency diet, ini pun penting. Kadang-kadang patient cakap asyik-asyik bagi nasi, tak boleh nak makan nasi. Patient maybe have this appetite but unable to tolerate the different consistency of the diet. So we need to offer, okay? We need to offer and inform the ward or staff nurse to indent diet accordingly. Okay? So any fat diets actually do not use any dietary provision that restrict energy intake in patient with or at risk of malnutrition, especially if patient on treatment, because insufficient intake, energy intake, protein, fat, and micronutrient deficiency occurs if patient follow this type of diet. Actually, there's a ketogenic diet come out, and then the currently fasting during chemotherapy. All these fat diet, actually there's inconsistent clinical evidence. Do not recommend to use this type of diet, although there's some recent study that is coming out, because this diet actually will increase patient dah malnourished, increase the risk of malnutrition, and patient might be tempted to prolong the fasting episode. Okay, oral nutrition supplement. Okay, this is the available ONS that available in the market. Okay, so there's a glycemic target, there's a fluid electrolyte, and then also there's an immunonutrition formula. So as a dietitian, we need to be creative in using this oral nutritional formula to give the benefit to patient. Okay. So for immunonutrition in upper GI cancer patient undergoing surgical resection, so this immunonutrition is recommended based on the ASPEN guideline. Okay, but now they come out with this pharmaconutrient. But pharmaconutrient, the amino acid to increase the fat-free mass, still there's insufficient consistent clinical data. But the most important is patient to receive adequate energy and protein intake. Okay, so managing nutrition impact symptom. So if patient at risk for developing any nutritional impact symptom or any side effect from the treatment, a dietitian should see the patient within the first week of the treatment. Okay, you need to educate patient, to help patient encounter any nutrition impact symptom. Okay, before the symptom occur. Nak kena tahu, contoh macam kita kata tadi radiotherapy, week 2 patient will have this type of problem. So in week 1 we see the patient, we counsel the patient. Okay, so they know what to expect and what to do. Okay, so this is the example of nutrition impact symptom: anorexia, cachexia, dysphagia, dumping syndrome, nausea, vomiting, any oral complication, diarrhea, altered taste, altered smell. So this management you need to manage accordingly, specifically for this patient. Okay. So mucositis. Mucositis is the most common, either patient on chemo or radiotherapy, and it's begin as early as day 5 after chemo or up to day 10. Okay, and usually if patient have this mucositis grade 2 for patient undergoing CCRT, usually we will recommend for rice tube feeding insertion if patient have this significant weight loss, tak makan, not comply with ONS, we will suggest for rice tube feeding. So the transition feeding. Transition feeding often requires a team approach. If patient has dysphagia, a swallowing evaluation by speech language pathology is recommended to verify the safety of oral intake. If the patient can eat safely, calorie counts should be conducted to quantify oral intake. ONS can be used to mark up any deficit, and one patient able to consume 50% orally, tube feeding can be decreased, can be weaned off gradually, and tube feeding can be discontinued when patient is meeting 75% of nutrition needs orally. Okay, so the nutritional intervention in patient with chronic insufficiency dietary intake or uncontrollable malabsorption, for example, vomiting, diarrhea, home in-end or home parenteral nutrition may be suitable for patient. But PN, we have to see the survival. If the survival more than a week or two, maybe it is beneficial for patient. If not, only for comfort feeding orally. So transition to home, the discharge plan is very, very important because sometimes patient cakap, ingat, oh dekat hospital aja perlu ambil benda-benda kat rumah, not on treatment, tak perlu dah. Okay. But patient need to be teach and need to be motivated to continue this intake to prevent any weight loss. So the discharge plan include formula, feeding regime, and the cost of enteral product is also another consideration. Okay, and the family support. Kalau patient tak faham, tak apa, we need to include the relative into this feeding regime. So in summary, so if let's say patient for counselling, you focus on high calorie, high protein, manage any nutrition impact symptom. Lain patient lain. Why? To maintain and improve nutritional status. If let's say oral intake is inadequate, top up supplement with ONS. Okay, if ONS inadequate, start with rice tube. And let's say if EN is not suitable or feasible, then we can discuss with this. We call it cancer team care to to suggest for parenteral. But you need to weigh the risk vs the benefit. If let's say for patient prognosis less than 2 months. So the limitation in this nutritional intervention, because the compliance with this oral nutritional supplement is the is common issue in cancer patient receiving nutritional support. Patient tak comply with this feeding regime, the dilution, suruh minum 4 kali, minum 2 kali, suruh bancuh 6 scoop, patient akan bancuh 2 scoop, 3 scoop, or the palatability. Sometimes it's because of patient anorexia, maksudnya dia limited, tak boleh ambil, early satiety, patient preference to consume normal oral food intake, then ONS. Ada patient dia tak nak susu, dia nak makan aja. So kita kena this other limitation. Sometimes patient only reporting desirable amount. Kita dah bagi dah sleep feeding regime kat patient. Bila doktor walk round, doktor akan cakap balik apa feeding regime tu, whereby dia tak sama dengan sepatutnya. Patutnya kalau patient comply, of course ada weight gain, but ini weight semakin turun. Patient too ill, forget to write down the oral intake, maybe under reporting could take place. So ini kalau kita in patient, for us maybe there's inadequate energy and protein prescription, lack of communication skill. Okay, we need to communicate well. Okay, with our team, with the nurses, with the doctor. Doktor kena tahu apa yang kita prescribe, and there is no follow up. If no follow up, sometimes is unable to achieve that target. So there's a recent study that claimed that patient compliance with nutrition therapy has been suggested to increase when it is prescribed and supervised by oncologists rather than dietitian. So basically, maybe this is only statement. Okay. So ways to improve compliance, actually we need to focus on patient education and awareness. Patient kena ada empowerment, kena play an active role in this treatment and recovery. Bukan kita je yang bagi tahu apa yang perlu buat. Patient kena tahu why they need to comply. Okay. And then let's say weight loss kita bagi turun, maybe we need to justify more concentrated ONS. Or we can improve the palatability of the supplements, added any flavor ke, okay? And then maybe flexible nutritional intervention, but this one need to further discuss with oncology. Maybe we allow lower intake during treatment days, but higher nutritional goal to catch up between cycles. But this one maybe only during chemo, okay? So it's very important to screen the patient regularly. And then if let's say patient is given this nutritional intervention, stepwise manner, okay. However, benefits and risks of this nutrition intervention have to balance with special consideration in patient with advanced disease, okay. And it should be based by evidence-based current guideline, and quality control is very, very important. Okay, such as the calorie given, the monitoring part should be established at each institution involved in treating cancer patient. So providing high quality nutrition care means doing the right thing at the right time, in the right way, for the right person, and achieving the best possible result. So there's a 4 take-home message for today. First, early nutrition intervention is very, very important. Focus on high calorie and high protein diet to meet patient requirement and to prevent the weight loss. You need to monitor patient and communication and teamwork. With